All right. So first, I wanted just to say thank you for allowing me to take the time in the morning here to come and present to you today. I'll be covering a lot of common side effects of cancer treatments on oral health and the importance of oral prehabilitation, which is kind of an anticipatory care for oral tissues before the side effects even develop. Preventing side effects and minimizing the severity is kind of the goal. And then I'll go into myself in just a moment. Let's see here. So I do have 25 years in the dental industry. I'm an expanded practice dental hygienist, which means that I can assess, educate, and provide some services independently. I bill Medicare and Medicaid accordingly. And I see a lot of oral health needs in my office and in our community that are not really met daily. So I'm striving to be a part of kind of a changing wave of dental professionals that'll fill the gaps between medical and dental care in my career. And I chose Compass Oncology for doing a presentation here because of my friend Tana that works there at the Tiger Clinic. This is a link to my website, and on here you can find links to some products that I recommend to patients. I have them organized by symptom. So if you go to the page and you find a menu for oral health products, you can find the symptom of patients and some recommended products that I often discuss with patients at work at the dental office. And you'll find contact info for me and some information about what I do when I'm not working clinically as a hygienist. So at our core, oncology and dentistry and medical and dentistry, we both have concern for our patients' quality of life in common. And that's why I'm here today. Here's a few key concepts to pay attention to during the presentation. I won't spend too much time on those because we'll just get into them here and you probably have questions yourself that might be answered throughout this. And I'm kind of bringing this down to a 101 in a lot of places where it's really simplified. So hopefully anybody that sees this can kind of get a little bit of an understanding of things. So chemotherapy affects salivation, even in cases of non-oral cancers. The infections happen easier in sensitive, dry, painful gums and tissue that bleeds easy. Without having good saliva, there's harder to maintain the pH of the mouth. And you probably know that children that receive treatment have developmental issues with their teeth that are affected and long-term dental problems after treatments. Most chemotherapy drugs target cells that divide rapidly, just like the healthy cells of gum tissues do, which is why they're more susceptible to treatments and being affected by treatments. And infections spread to the rest of the body by entering the bloodstream through bleeding areas in the mouth. The gums and tissue of the mouth provide a protective barrier. There's 20 billion bacteria that live in the mouth, and it's about 500 to 1,000 species, a lot of which are gram-negative, which causes a high incidence of infection, not only in the mouth, but throughout the whole body. Most oral health problems are predictable and preventable or manageable, yet they can cause declines in quality of life and delays in cancer treatments. The top 5 on this list here are the most common side effects that I see at work. I don't often see osteonecrosis of the jaw, probably honestly, maybe twice in my whole career as a hygienist. And it could be just the demographic of people that I see at my job, probably a higher incidence in more lower income physicians or public health, I imagine. So this is kind of an ideal scenario. It's if you were to have a dental health professional working in your clinic. It's kind of touches on things that I do daily in my chair as a hygienist as well. So I'll just kind of review these a little bit. Ideally, an oral health assessment will take place at the first visit to the oncology clinic to get a baseline of health and start the referrals process as needed for patients. And follow-ups can be provided using telehealth platforms a couple times a month. So steps of the assessments that we do daily as hygienists is identifying health issues and dysbiosis. We check the fit of appliances, dentures, retainers for areas that can irritate tissues, and then we can adjust them or modify them for better fit. We review social histories and current home care practices. And we give instruction, of course, on oral health routines. We do cavity risk assessments, nutritional counseling, smoking cessation, and we review medications as well. Education, motivational interviewing about disease and cavity prevention is something that, of course, you're probably aware that we do. We apply topical treatments for cavity prevention and fabrication of fluoride trays as needed, though it's probably a good preventive step for a lot of patients to be done before there's issues. Prescriptions and product recommendations specific to the patient's individual oral health needs are something that we do daily also. And referral to dental homes and support and follow through with social workers to complete appointments and receive the treatment and complete the treatment that's recommended for patients, especially when they're going to go into cancer therapies. And so this is kind of a basic summary of what oral health assessments are. It gets very complicated when you individualize these. And ideally, this would be done in a medical setting in the future as we kind of expand and connect the medical and dental fields. So let's have a look at this child's teeth and gums, and feel free to answer me here if you're able to unmute. I just wanted to ask what you notice about the teeth and the gums in the picture, if anybody has any. Tana, I see you're unmuted. What do you see?
So my picture is very small because I'm on my phone,
Yeah.
but they're very yellow, and specifically in the front.
Yes. So on this picture, what I see is, of course, the yellow. Yep.
And you see inflammation at the top. Well, I see it
Yeah,
most
there's
at the top.
some ridges of inflammation at the top and at the bottom. There's puffiness. There's food debris here. Dryness in the gum tissue also. Decalcification is kind of this little white spot that's starting right at the top of the tooth. This is a precavity where tooth structure is weaker and it's susceptible to acid wear and bacteria invading it. So just by looking at a picture, we can see quite a bit. But after we use disclosing solutions, we can identify plaque buildup. And basic discussion of plaque is it's a residual film that stays on the teeth, even if toothbrushing, especially if toothbrushing is not done correctly. This plaque feeds gram-negative bacteria and increases their numbers in the oral cavity. The darker areas here are a biofilm or plaque that's days old, and pink is fresher buildup. When plaque is on the teeth, it creates acid and keeps feeding those gram-negative bacteria, which evolves into our side effects with that inflammatory process. This is why it's so important to assess and educate our patients and then demonstrate and motivate them to keep good oral hygiene practices and keep their mouths healthy. Here's some common examples of what we see in the dental office before and after cancer treatments. There's definitely no single way to prevent the side effects, and not all products work for all patients. So those individualized care plans and recommendations to prevent and minimize these side effects are going to be very important. A lot of them we can minimize the severity significantly with good oral home care and education through the course of therapy. Mucositis, dry mouth, and bleeding and infections are 3 times more common in children than in adults going through cancer therapies. Preventable causes of mucositis include dehydration, problems with nutrition, poor oral home care, pre-existing dental issues like gum disease, cavities, infections, decay, rough surfaces that are on teeth, retainers, appliances, and medications, and of course, cancer therapy. We might think that drinking more water will help mucositis, but despite our need for water, if people overhydrate, it can actually dilute the saliva and patients will still feel dry, and we will still end up with dry mouth and mucositis issues too. So the clinical presentation of mucositis, which we often see is, and I'm pretty sure you're familiar with it in your clinic, is that the tissue's red, shiny, swollen, sensitive, and there might be active sores in the mouth, on the gums, or the tongue. Patients probably have soreness and pain in the whole mouth and in the throat, and they can experience dry mouth, burning, pain with eating. White patches can appear on the tongue or the tissue, and saliva can be thick, sticky, stringy, or kind of like a mucus instead of saliva. And these all lead to difficulties eating and swallowing. Now, if you see patients that show up and they have sores all over the mouth, on the cheeks, kind of everywhere, that's exactly what we're hoping to prevent with good oral home care and kind of the prehabilitation concept for the oral hygiene of the patient. Recommendations to prevent and minimize mucositis include improving home care, of course, which we'll look at in a bit. Baking soda and water to squish with. This neutralizes pH and reduces sores in the mouth. Application of stannous fluoride, which is both bacteriostatic and bactericidal, but can be irritating to the gum tissue. Xylitol has known to have a wound healing effect, and it's soothing and cooling for gum tissues. And there's different products from lozenges to sprays that have xylitol in them. There's a lot of products now on the market, thankfully. Glutamine found in eggs, milk, nuts, cabbage can reduce the severity of mucositis and aid in healing from it. And a capsaicin mouthwash has been shown to provide a lot of comfort to patients. That's just adding a mix of 5 to 6 drops of Tabasco in 1 teaspoon of water, and people can kind of swish that around their mouth, around 4 times daily. Probiotics are being studied to lessen the impact of mucositis, especially L. reuteri and Bliss. And then there's a product called Gelclair, which is considered a prescription medical device because instead of having medication, it actually provides a coating on the mouth. But it's very hard to find and access. I'm not entirely sure why. So whether you find it in your clinic or not, let me know. And here's another question for you if somebody can answer. Do you recommend magic mouthwash to your patients? Because many clinicians still do. All right. The American Journal of Nursing does not recommend the use of magic mouthwash or mixed medication mouthwash. It doesn't have a direct effect on the pathogenesis of mucositis, and it's simply a palliative treatment. The ingredients that are often used in the prescription have high sugar sweeteners, and some are acidic, which causes a drop in the pH of the oral cavity and feeds bacteria, leading to irritation of the gum tissues and increases in cavity rates. Instead, we recommend Helios, biotin, sodium bicarbonate rinses, and of course, prevention is the biggest thing. Also, a lot of patients might show up with chlorhexidine. Some doctors, dentists might think that they're dealing with periodontal bacteria in the mouth causing the redness and inflammation when it's the inflammatory process. So chlorhexidine also doesn't have an effect on the pathogenesis, which starts mucositis. Here's a couple of photos of cavities and what they look like. White lesions are often considered pre-cavities. Like I mentioned before, these are where the enamel is damaged. It's weak, it's porous, it's less resistant to decay and acids. And there actually might be cavities underneath the surface, something that a dentist can identify with an x-ray. And then the dark pit on the right here, I think is kind of speaks for itself. If anybody saw that on their tooth, they'd probably think, oh, I've got something going on. I've got to go see my dentist. And though cavities are generally preventable, it's one of the more common chronic diseases in America. It's the most common chronic disease among children and adolescents. And on average, people miss about 3 days of work a year due to tooth pain. There's about a quarter of adults, as you can see, in ages 24 or 20 to 44 and 45 to 64 who don't have haven't had treatment for active cavities in their mouth. So recommendations, of course, for cavity prevention is preventive applications like fluorides and sealants. There's a product called silver diamine fluoride, which stops cavities, and it decreases tooth pain also. So it's a good treatment for patients who can't get to a dentist or financially can't afford to go to the dentist, or for health reasons, maybe they can't leave the house. However, it turns the cavity black, which is kind of in this photo here. And so, and that's a side effect of the silver in it. That is bactericidal. Reviewing, demonstrating, educating, and motivating patients and caregiver on home care routines is going to be really important. Checking medications for pH levels, and if they have citric acids or sweeteners that can cause cavity rates to increase. We also need to check medications to see if they're recommended for use at night, if there's any contraindications, and what the purpose is. Does it increase pH? Does it stimulate saliva? Is it for soothing the tissues? And all of those effects can affect the tissues depending on what's created for. Keeping the mouth moist maintains a better pH level and helps maintain the mucosal barrier, which protects us from infection. And xylitol wipes and rinses can be used if toothbrushing is not an option. Bacteria can't metabolize xylitol, and so xylitol is something that bacteria are drawn to, just like sugars, but because they can't metabolize it, it essentially starves them. Dry mouth and burning mouth usually happen together. We often see those go hand in hand, not always, but often. And so saliva with the dry mouth is very important for us. It protects our tissue. It keeps fungus, bacteria, and viruses at bay. It contains mucins that protect us from staph. It provides digestive acids that break down food for our nutritional absorption. And then 20 minutes after we eat, it rebalances the pH of the mouth to do its job of protecting the tissue again. It also helps us comfortably wet and masticate foods into our enjoyable amounts. Recommendations for dry mouth include cryotherapy, of course. Improved home care can prevent dry mouth quite a bit and make it more comfortable. Products that help provide protective barriers are also recommended. And then dry mouth lozenges that are pH neutral, like Xylamelts, which is what's here in the photo. You stick it on your gums and it helps keep saliva stimulated, but it won't increase cavities. They're preferred because the saliva stimulation, saliva has the good enzymes and proteins that substitutes are missing. And then probiotics might help some people in decreasing the discomfort of dry mouth also. Of course, humidifiers, lip balms, photobiomodulation is also being studied for improving the comfort of mucositis in dry mouth. Drinking water, of course, but don't overhydrate because that thins the saliva, which makes it not as effective in its purpose of protecting the mucosa. And bacterial and fungal and viral infections are common, as you can imagine, and you probably also see at your clinic, I am sure. When the mouth is dry and the pH level is perfect, those gram-negative bacteria just take over. Candida is something that's or thrush is a naturally occurring infection in the mouth, but it can take over when conditions are right, as you probably often see. Because lowered immunity increases infections also. So thrush, like we mentioned, is kind of the most common infection that we see during treatments and in patients post-treatment too. Pneumonia can be prevented with home care improvements and reduced oral bacterial load. But unfortunately, the best treatment for fungal infections are prescriptions, fluconazole or nystatin, amongst many. And finally, there's always a lot of questions and interest about osteonecrosis of the jaw. Here's kind of a few examples I could just find online. like I mentioned, it's not something that I see very often or commonly. And sometimes people might just have very small things that perhaps a dental clinician who's not really looking might not see. There's just a little dot here. Um, I have found in the past that some hygienists, because we don't learn a whole lot about osteonecrosis in school, um, depending on where this occurring, it might be happening right behind a tooth, and a hygienist might think that it's tartar buildup or calculus and be scaling on it, thinking that it's something that they need to clean off, which of course is kind of a frightening thought. But so a lot of patients that suffer from osteonecrosis also have a history of dental disease, like periodontitis. They might have a high cavity rate or infection rates, perhaps have a history of having quite a few root canals. And then the jaw is the most susceptible bone because of the high turnover rate in that bone compared to other bones in the body of the bone, because it's constantly remodeling to retain the teeth. Biphosphonate drugs are not metabolized fast enough because of that really fast overturn of the bone, and it causes a higher concentration to remain in that area. So of course we know IV biphosphonates increase risk along with the length of treatment and the total amount of dose. But I found this interesting when I learned it. One of the common things, one of the common areas that it can start to occur is in tori, which we see in the photo. This is an area, it's kind of like, it's a normal occurrence on many people. So it's just a variant of normal, but because this is really covered in thin tissue, it has a higher likelihood of trauma. And it's trauma extractions, trauma to the tissue and the bone that can kind of start that infection process where the bone starts to die and doesn't heal. And then, of course, other dental diseases, age, being female, and other inflammatory comorbidities also increase risk. Patients might not know that they have an issue at all. There might not be anything noticeable that's abnormal on the x-rays for years. There might not be any symptoms except for maybe jaw pain, whether it's chronic or transient, or numbness. In general, the occurrence of osteonecrosis is pretty low. It's kind of interesting that it goes up 1% per year. And who knows, if it would keep going. So guidelines, there's nothing really groundbreaking here. It's probably stuff that you guys are a little bit familiar with. Of course, completion of dental treatments prior to therapy is recommended, educating about the significance of good oral hygiene and regular checkups during and after treatments. Extractions and surgery should be avoided. Root canals are preferred, and we can do a crown amputation, which is the photo here where they just cut the tooth off right at the gum line after a root canal is done. And usually they'll cover it with a filling so it looks better. Tests can be done if necessary to check levels kind of the telepeptides for bone turnover rate. And it's recommended to take the patient off of biphosphonates for at least 3 months before treatment, and then only resuming treatment after healing has completed, after the extraction or the oral surgery. The American Dental Association recommends that dentists first consult with a prescribing provider about the patient's treatment needs, and then avoid any extra invasive procedures, and giving the patient prescription chlorhexidine to rinse with 2 times a day for 2 months post-surgery. Patients should follow up with the dentist after 2 months to check for any abnormalities in healing. Overall, 40% of patients that receive chemo and 80% of transplant patients will have oral side effects, and these are often problems that last long after treatment. There's also secondary side effects from discomfort, as you can imagine, when the gums hurt, when things are dry, when it's hard to eat, painful to eat. it can cause a lot of these secondary side effects. In a 2013 study, 97% of cancer patients needed some form of dental treatment before beginning therapy, but only 81% completed any treatment, which is higher than I expected, actually, but still not ideal. And so, do you guys have any ideas what prevents patients from getting dental exams and getting treatment completed? Cost is probably a big one. Patients might not know that there's free or affordable options. They might not understand insurance. They might not have insurance. They might not be able to take time off work. There might be transportation problems. Childcare might be an issue. 50% of Americans don't have a dentist. There could be language barriers, different cultural views on preventive dental treatment. Physical or mental stress can also stymie motivation for getting treatment completed. There's a lot of reasons. And of course, social workers and dental health professionals, we have a lot of public health training that can help identify and address a lot of these issues with the patients and give them the treatment that's needed within their community. Here's some of my favorite things. I love numbers and some statistics and stuff. So this is the next few slides are in 2017 dollars, and so you can imagine prices have gone up by now, so we can only imagine how much more a year a lot of these slides will be. But in 2017 dollars, the cost of mucositis for hospitals and clinics was about $5,000 to $30,000 a year per suffering patient. Osteonecrosis of the jaw added $4,000 to $35,000 a burden on the healthcare system per patient. Management of dry mouth costs patients up to about $200 a month, and this could be for the rest of their lifetime sometimes. Decreased nutritional intake and increased hospital stays cost the healthcare system about $40,000 per CLABSI case. And CLABSI is pretty tightly correlated with oral health. The mucosal barrier, like we were talking about earlier, is a very protective barrier that keeps bacteria inside the mouth and inside the digestive system. And so when this layer breaks down, the gram-negative bacteria can travel into the body, into other parts of the body, and causes infections such as CLABSI. The Massachusetts Health Policy Commission counted more than 36,000 preventable emergency room visits for oral health problems in 2014, and this cost their healthcare system as much as $36 million, which is about $1,000 a visit to the ER, which studies have shown that's about the cost per tooth visit pretty regularly, versus $100 to $200 to see a dentist. And this is just in Massachusetts. Every year, thousands of patients go to the emergency room for dental pain and dental discomfort or oral health issues and discomforts. Johns Hopkins Hospital implemented an oral care bundle in 2016, and this led to a 50% decrease in oral side effects like oral mucosal infections. CLABSI cases were similarly decreased by 70% at St. Jude, with a similar oral care bundle. The bundle includes products and instructions for toothbrushing and lip care 2 times a day, and oral mouthwash 3 to 4 times a day, and cryotherapy during infusions. And prevention, of course, is the best option to retain the oral health and also retain and maintain the quality of life for our patients. We don't want our patients to beat cancer and then end up with a huge dental bill and lifelong dental problems. And, you know, having to go in to get dental treatment that could have been prevented before and during therapy. Extra soft toothbrushes for for active prevention, extra soft toothbrushes, brushing every time after eating, wiping with gauze if there's an especially low white blood cell count. You want to remind patients to cover their toothbrush with a breathable barrier, even a washcloth. There's little toothbrush covers that are fabric that you can buy on Amazon. Placing it away in a drawer, some way that it'll avoid being contaminated by toilet flushing or aerosols in the bathroom. Sharing is not caring. Don't share toothbrushes, toothpaste, mouthwash because of bacteria. People get bacteria from just getting their mouthwash straight from the bottle and not using the cap. People get bacteria from eating. People get bacteria from kissing. We just want to decrease that load during the treatment. And floss regularly unless otherwise advised. So most specialty medical teams don't include a dental health professional. This leaves a large gap in the overall care we give our patients and prolongs disparities in oral diseases that are predictable and preventable. Treatment of cancer should be approached by a team of professionals, including oral health providers, to address the dental needs and provide education, referrals, individualized prevention and treatment plans, and management. An experienced dental hygienist, we can identify signs of gingival issues and risk factors in the oral health really early. And then, of course, have our knowledge base of pH and sweeteners and products that can help the oral cavity be more comfortable and reduce some other issues. And then, again, with our public health training, a lot of resources to connect patients with community dentists and places that they can get affordable care if needed. So adding a dental hygienist on staff could alleviate some responsibilities for nurses and improve patients' overall well-being through their cancer journey. But it takes all of us working together to fill the gap. And that's a wrap for my presentation. If you'd be kind enough to fill out the survey, it would be very helpful for me to get an idea of what to add or what to kind of thin out. And you can always email me if you need to reach out as well. And that is it.
Oh, Tana, thank you so much. What a wonderful presentation.
You're welcome.
So this presentation will be made available to all staff, not just nurses. And also, as Tana noted, if you have any questions for her, feel free to email. And I'm going to include this. I'm going to send out a blast to our practice and just offer this video and your email address. And I think there's opportunity to bring you back maybe again for a bigger audience.
We certainly could, or if there's specific things that we want to do a deep dive into.
That's great. Well, thank you so much. I am going to sign off. Are there any questions from anybody before we end?
If not, you can always email me.
Okay, great. Thank you so much.
Thank you.
All right. Take care.
You too. Bye.